Hey, welcome back, everybody. It's time once again for another episode of Health Talks with Dr. Trinh. The one show, maybe the only show, that shows you the path to healthier living. And maybe, just maybe today, a path through the complicated healthcare system that we moan about so often on this show here. Dr. Trinh, welcome, sir.
Good morning, everyone. Yes, I'm excited to have this conversation with Dr. David Wilcox. You're out in North Carolina, is that right?
That's correct.
Okay, great. And you just released a book this year.
I did.
It has a very, very interesting title, and we are all waiting to hear about it.
So let's get the title out on the table here. It takes half the show just to tell the title here. It's a long title, but a big topic. So what's the title, Doctor?
It's How to Avoid Being a Victim of the American Healthcare System, a Patient's Handbook for Survival.
Wow. We're going to do all that in an hour because we have talked. This show's been on for a while now, over a year, and often we return to this topic that healthcare is the problem. We, in our quest to make it cheaper, faster, Medicare pays for it and gives the doctor 5 minutes to make the diagnosis, and the assembly line moves on, and it's a pay for service model. So we only see you when you're sick. Don't come when you're healthy. Just see us when you're sick. All of this, as well-intentioned, has led to some big problems, it seems like, in our healthcare system. What do you think, Doctor?
That's correct. Healthcare is complex, and that's not an accident. It's complex by the healthcare entities who are vying for your healthcare dollars. They don't want you to understand what's going on. And as we dive into this hour, we'll talk about what they're actually doing behind the scenes to make sure you don't understand what's going on so that you just pay your bill.
And I think one of the things, I'll set it up with my own little rant here, my own little feeling. I don't know if Dr. Trinh, who's a member of the healthcare system, will go this far, or you will. But it seems like it's sort of a rigged game in that it's designed to make a lot of money, and it's designed that somebody else pays for it, we feel, insurance, the government, somebody. So I, as a consumer, never question how much it costs. Whatever it costs, just fix me. Somebody else will pay for it. That's why I have insurance. And so the costs keep going up, and we, the public, keep paying for it. And the amount of time you get in front of the physician seems to keep shrinking and shrinking. Am I right? Are we sort of in this? It's almost like a death spiral. It's a built-in problem that's into the system that seems to get worse and worse every year.
Yep, and you're exactly right. So the physician is incentivized by how many patients he sees under the fee-for-service model. Right. But there is hope for that, and we'll dive into that as we talk through this next hour about what other models are out there and what you, as healthcare consumers, because it's different if you present as a patient. If you present as a patient, you have to access the healthcare system. If you present as a consumer, then you're trying to make an educated decision about what area of the healthcare system should you access and where are you going to get the most bang for your buck.
Good. All right. Well, we'll get into all that. Let's start with Dr. Trinh here. You're an esteemed member of the healthcare system, and yet you feel a little frustrated from time to time at the constraints of this pay-for-service model where you only get to see people when they're sick and you only get to see them for a few minutes because whether it's your desire, whether it's a physician's desire to make more money or just Medicare's desire to move people through quickly and the insurance company's desire to move you through quickly.
You're in the world of fee for service, right? Yeah. Where you only get paid when someone's sick. Then why would you be incentivized at all to promote wellness and prevention? Mm-hmm. Isn't that a problem?
Exactly. That is a problem, definitely. Yeah. So maybe, Dr. Trinh, we should talk a little bit about what the new models are. So we know here in America that socialized medicine is not going to work. Medicare for all is a big hoax, a political hoax, because Medicare pays 80% of the bill. Hospital systems depend on insurance companies or out-of-pocket payments to make up the rest of that money. If we went Medicare for all without a supplement, then we would see hospitals, community hospitals, closing up like crazy because they run on a 2 to 3% margin. Wow. So, anytime that a politician is dishing that in front of you, it's not going to work.
All right. Well, let me stop you for 1 second because I don't disagree with what you're saying. I don't know enough to agree or disagree. But that is a popular model that's being pushed, particularly among progressives, or Democrats, Bernie Sanders of the world, saying other Western countries do this. Why don't we just give everybody health care like we give them free education up to a certain age? You're saying that model is what, too expensive or not enough profit to keep the community hospitals alive?
Yeah, at 80% and running at a 2 to 3% margin in a community hospital, it's not enough to keep the doors open in community hospitals. Now, if you did it with gap insurance, then it would be a model that would be sustainable.
And what's gap insurance? I don't know what that is.
Gap insurance will cover the other 20% that Medicare does not cover. So when you get Medicare, you can get gap insurance so that when you get billed for a procedure or a test, that gap insurance will kick in and cover the other 20%. But Medicare by itself will not do that. It'll only pay at 80%.
Could Medicare be 100%? Could we just raise everybody's taxes and pay for it 100%? Don't they do that in like Scandinavia? You pay exorbitant taxes, but you get exorbitant services?
Yeah, but so I would say that in America, that's really not going to work. And because of our fee-for-service system, so we spend 17.9% of our GDP on healthcare, right? Compared to countries that spend 8.7, other industrialized nations. And people, we are dead last as far as quality outcomes. So you think you're getting what you pay for, but you don't understand it. And you start to do the research. We are dead last.
So why, not to go down another rabbit hole and chase this over, but people talk about this all the time. We pay a lot. As you say, a high percent of our, gross domestic product or GDP, we pay, you're saying 17% of that total that we generate as a country goes to pay for health insurance. And yet we're not top tier. We're not top of the line. We're at the bottom of the list when it comes to outcomes and prevention and health and whatnot. How can that be?
Well, we're incentivized under a fee-for-service model to write tests, to see people when they're sick. We don't really promote health, as Dr. Trinh said. So that's got to change. Fundamentally, that's got to change before the numbers start to change. And there is hope on the horizon. So I did a research study just recently, and about 25% of Americans know about value-based care, which is administered through accountable care organizations. So what that is the accountable care organization goes at risk to keep you healthy. They get a certain amount to take care of you for the year. And if you don't access the healthcare system, you don't go to the hospital, they get to keep the profit. It's genius. And it works, and the numbers are there to show that it works. So here's a little story about something that happened in my family.
Okay.
My brother-in-law got a hip replacement, and he was under a bundled payment, which is a value-based care model, meaning that they bundled everything, gave it to the surgeon, gave it to the PT people, and all of that to take care of him. Well, my brother-in-law, they gave him Percocet. Now, my brother-in-law, as far as I know, he's never used drugs. He doesn't drink. And so he had a reaction to the Percocet, and he thought he was having a heart attack. So he was immediately taken to the emergency room, and they did a whole cardiac workup. And Dr. Trinh, you know how much that costs, right? Yes. So they did a whole cardiac workup on my brother-in-law. And then they released him home and figured out it was his pain medication and gave him something a little bit more mild. And so the next day, my sister and I are talking, and she says, "Oh, it's just fantastic. There's these nurses coming out to the house, and it's all free to check on my husband." And I'm like, "Well, sis, it ain't exactly free. He was under a bundled payment, and they had to eat the cost of that emergency department visit." So they were incentivized to keep him home. Maybe if they had done a little bit more history on him to figure out he didn't need Percocet for pain, then they would have avoided that visit. But that's basically how value-based care works.
Now, I've never Have you ever heard of value-based care, doctor? Or do you know anybody doing it? Yeah.
Yes, definitely. Value-based care, ACOs, and things of that sort. What we need to move to is a direction where we pay for outcome.
Exactly.
Not procedures. Right now, you get paid for doing a ton of procedures, right? Regardless of the outcome, right? It doesn't matter if the outcome was positive, negative, or no outcome. You're paid for just doing procedures. And this is not like, this is not anything against physicians doing procedures, right? A lot of physicians live their lives based on the procedures that are specialized. A cardiac angiogram is a procedure, right? A treadmill, there's lots of procedures are being done, which is needed, right? You need procedures, but what is the outcome, right, of these procedures? Exactly. Does it result in a patient who's healthier? Or is it just a procedure that's being done? And
so let me give you an interesting. This is maybe a weird analogy, but I work for the Small Business Development Corporation. We help in digital marketing and whatnot. And a guy came to our office who is a Chinese traditional practitioner. Dr. Trin's going to have him on the show here, and so he does acupressure, acupuncture, that sort of thing. And I said, well, it must be wonderful that acupuncture at least has been accepted by medical science as a pain alternative. I don't know why or how, but more and more insurance companies will pay for acupuncture, at least to manage pain. And he said, oh, very bad. I'm sorry, he has a very thick accent, so I don't want to imitate him. But he said, very bad. I said, why? He said, because it takes away the incentive for the acupuncturist to really find the problem and cure you. He's getting paid. Right. The more time he puts pins in your body, he just keeps getting paid. And he said he believes, where they are no longer trying to find the underlying pain and really solve it. They're just kind of prolonging the pain almost to keep getting paid. That's a horrible, horrible assessment. But he said it took, whereas in traditional Chinese medicine, he said, you got fired if somebody got sick. You're there to keep me from getting sick. It's a different approach to medicine. And now, because it's become westernized, it's a pay for procedure. And therefore, let's keep the procedures going. What do you think of that? Is that got light? Is that real? Yeah.
Yeah, there are alternatives for cancer that we don't practice in this country only because the pharmaceutical companies are making a killing off of chemo drugs.
No pun intended, a killing off a chemo drug.
Yeah, right. Okay. So let me tell you a little story about an oncologist that I know. He was treating somebody that was very near and dear to me, and she had stage 4 cancer. Okay. And so he wrote a prescription for the chemo drug. He sent it in, and the insurance company called him and said, sorry, you can't use that type of chemo. You have to use this type of chemo because it costs less. So what a lot of people don't know in the American healthcare system, there's this role called pharmacy benefit manager. They sit between the supply chain of the pharmacy and the insurance companies. And when the role started, it was a much needed role. They were actually looking for generic prescriptions for you and to drive costs down. Right. Then they slowly got bought up by the pharmaceutical industry. So they changed their model. And so the oncologist said, no, I don't want that chemo. I'm telling you, I want to use this chemo. I know my patient's history. And they said, I'm sorry, the pharmacy benefit manager said that you have to try this. It's cheaper. You can try this. And if it doesn't work, then we'll bump you up to the chemo that you want.
Right.
He said, I want to talk to the person who made that decision. And they said, well, you can't.
You can't.
You can't. They won't even allow these guys to get on the phone. They're very well protected. But what they're doing is they're using coupons. They're using incentives that they get from the pharmaceutical industry to pocket the difference in cost. And people just don't know about this role, this pharmacy benefit manager. But that's one of the reasons, and there's several, why your prescription drug prices are so high.
So they're recommending what they're getting incentivized on in the system, and not necessarily what works the best.
Explain how the coupon works with these PBMs.
Okay, so they actually get
what's a PBM? You got every time I'm going to stop you guys every time you give me an acronym because you just rattled off 20 of them. Oh, PBM and an APB and a 4 or 5. I don't know. What's a PBM?
Pharmacy benefit manager.
Pharmacy benefit manager. All right. I think I'll interrupt you for one more second. I think that's part of the gobbledygook that keeps this unintelligible for most of us. There are so many of these terms and acronyms and complicated things that we don't even bother. And I think that's almost by design. It's so complicated, the consumer can't figure it out or won't figure it out.
Right, Paul. You got to remember, medicine is based in Latin. How many of us know Latin, right?
I actually studied. I'm a good Catholic. I studied Latin for years. I'm sorry to say, but anyway, yes, right. I got it. All right. The law is the same way, and I go down another rabbit hole. I did go to law school for a year, and in the first year, it's crazy confusing, all these Latin terms and ideas and stuff. And then a light bulb goes on. You said, "Oh, why can't they just say it in English?" And the professor I had said, "They don't want to. Because if they make it too easy, everybody will figure this stuff out. You have to go to a lawyer to decipher this gobbledygook." I somehow think that's the same with medicine.
The pharmacy benefit manager is an organization that is between the health plan, your insurance company, and you.
Right.
And the pharmaceutical company. Yes.
And the pharmaceutical company. So they're like an intermediary. Right. And so their original role was to lower medication costs by, maybe pushing more generics.
Find generics that are cheaper.
Okay. So how has it changed now? Is it the pharmaceutical company having a bigger influence on these PBMs? Are they acquiring them? Are they buying them? Or what's going on?
How are they influencing them? Right.
Yeah, they own them. And so the pharmacy benefit manager, you asked about the coupon. So if the pharmacy benefit manager, Dr. Trinh, if you prescribed me low pressure, let's say, and you said, okay to fill generic, if the pharmacy benefit manager had a coupon for the brand name, I would get the brand name of the drug, not the generic. And I would and it would increase my out-of-pocket costs while he used the coupon or she used the coupon to pocket the difference. So that's how it works.
So I'm going to go one step beyond this. All right. So a drug company comes in and says, we have this one that we own the name to, and therefore it costs more. We're trying to, it's our proprietary drug that we developed, and there is a generic version of it that's cheaper. Don't use that one, the drug company says, and we'll give you, the benefit manager, a coupon. So it looks good. I've reduced the cost to be the same. If the same cost, but you only get to use this coupon and the savings if you use my drug. It's an incentive to use my drug. Yes. So there might be other drugs like you're talking about that are cheaper, better, faster, but they have entered the system and gamed it by artificially reducing their cost, which then gives an incentive to not use other alternatives. Is that correct?
Yeah. Let me break it down to a real world example.
Yeah.
This is kind of a funny story, but it's something that my wife and I went through. So we had a 16-year-old English setter. Her name was Pippi Lou, and she developed some heart problems. So the vet, and remember, this is away from the insurance company or anything. The vet prescribed Viagra for my dog. Okay. And no, before you guys even go there, I did not dip into it. I'm just saying.
All right, come on. All right. Just a way to get free drugs.
So they prescribed Viagra because that's a pulmonary antihypertensive drug. It was only after they discovered the side effect of it curing or helping erectile dysfunction that they decided to jack the price up. And yeah, I know I shouldn't use the word jack, but anyway.
Yes.
But anyway, so my dog, she went to a pharmacy to fill it for my dog, and it was over $700, right? And she was like, I love my dog, but I'm not paying over $700 for a month's supply. Yeah. I mean, and so she went back and she downloaded the GoodRx app. The GoodRx app actually works with pharmacy benefit managers to get you a better price. Sometimes it's cheaper than your insurance, right? Except they don't apply your copays or anything like that. It doesn't come out of your what you have to pay every year out of pocket. Right. It's more of a cash transaction. She found the same drug across town for $63 for a month's supply. So my point being, if you can sell it at $63, because we know the pharmaceutical company does not give anything away, right, guys, and make a profit, then what are you doing selling it at $700 across town for a month's supply? And the average American consumer doesn't know that this kind of stuff is going on. You take your prescription to one pharmaceutical company, Walgreens or something, that's going to cost a certain amount. You take it to CVS, it may cost less, it may cost more. So it's just It's just shady business.
But is that part of the problem that's baked into this too? Is that the person consuming this drug, using the service, isn't acting like a consumer? I don't care what it costs. I somehow don't get a bill, so I never go out and shop. There's no incentive for me to go around to Walgreens and CVS and say, wait a minute, I can get it cheaper over here. Or even to use this app that they advertise on TV all the time, Good RX, where they will compare and do this. Right. What's the incentive to me? Because I don't get the saving. The drug company or the medical insurance company might, Medicare might, but I, the consumer, don't see, because somebody else is footing the bill. I seem to not care what it costs.
Not coming out of your pocket.
Not coming out of my pocket. There you go. Is that part of the problem?
That is part of the problem. In fact, there was an executive order that President Trump put into effect, and it took place in January of 2021, in which healthcare entities, hospitals, had to list out their procedural costs for a bunch of different procedures that they're doing. And so 95% of them aren't doing it in a customer-friendly format. I researched it, and it's actually in my book, How to Avoid Being a Victim of the American Healthcare System, where I provide an example from my local hospital here in Charlotte that shows you would need a medical coder to figure this out, right? So I went in and looked for a total knee for somebody who didn't have insurance, and the gobbledygook that I got back was incredible. So 95% of the hospitals aren't doing this, and because they're only getting fined $300 a day, which is roughly about $110,000 a year. But they don't want you to have this information.
No.
So as you said, you don't ever really see the bill. But with a higher price deductible, if you get a total knee done in a hospital in my area using Healthcare Blue Book, and everybody should write that down, Healthcare Blue Book.
Okay.
Yes, because it will give you a ballpark figure of what a procedure costs in your local area. So in my local area, total knee done at the hospital is $12,000.
Okay.
If you get it done in an ambulatory surgery center, it's only $8,000. So
because you're not staying overnight, you come in, you go out, right?
Right. So if you're healthy, an ambulatory surgery center is a good alternative for you. If you've got a lot of comorbidities, you have diabetes and, congestive heart failure and you're obese, you need to have it done at the hospital.
Right.
But people just don't know this stuff. They don't shop. And that's part of the reason why they don't want to give price transparency to Johnny Q public, because they're afraid that these guys will start to shop around for their health care. The hospital system that I'm talking about too only has 2 stars. So that's another thing. CMS ratings for physicians and hospitals are something every healthcare consumer should be looking at.
What's a CMS rating? Another acronym.
Centers for Medicare and Medicaid Services.
Okay. And that's a site that I can go to and get ratings for different providers. I didn't know that.
Yes, and hospitals. Okay. Providers is you have to dig a little bit more, but the hospitals are right up on top. You can find them pretty easily.
All right, so now we've identified one of the problems, that the consumer just doesn't shop, and if they do, they can't understand what they're shopping. I don't even know what I'm looking at when I look at these bills or costs or everything, and there's these intermediaries supposedly looking out for my benefit, but they're being influenced by outside incentives and coupons and other things here. All right, the other problem is this, and without spending the rest of the hour explaining this to me, it's like an airline flight. Everybody sitting on the plane didn't pay the same price for that seat. You bought it early. You bought it late. You bought it through something else. I bought it on using points. Everybody's got a different. If we all got together and say, what did you pay for this seat? The same thing, the seat in a hospital. One guy is paying a lot. One guy is paying very little because they've got better insurance or they've got better employee benefits or other sorts of things.
Yeah.
That skews the whole thing too. I don't even know. So for example, you get these bills and it says, oh my God, my heart replacement was $1 million. And then what's my copay? I don't know. If somebody pays this and somebody else pays this and somebody else pays this, you don't even know what you're paying for out of this.
Yeah, exactly. So that's done by the insurance companies. So insurance companies have a lot of clout. They can say, hey, I've got 600 patients that are going to come in for total knees this year. I don't want to pay X amount of dollars. Now if you don't have insurance and you come in for a total knee, forget it, man. you're going to pay top dollar unless you know how to negotiate with them, which I also cover in the book. But you're definitely going to pay whatever your insurance company says. Good example was I had and you alluded to this, Dr. Trinh, a cardiac stress test on a treadmill when I was living up in Greensboro, and then the test cost about $2,500. I think I might have paid $400 out of pocket for it. And my wife had one down here, and she was out of network, and her test cost $12,500
for a stress test.
Yes, for a stress test. Talk about stress.
That's enough to have a heart attack.
Oh, there we go. Exactly. That's the joke.
Wow.
So, but the insurance company, my insurance company, because I'm self-insured with the company that I work for, paid $11,000 of it. So it wasn't terrible, but still, what a difference, right? And,
so
who knows? Yeah, who knows when you walk into that?
I do treadmills as an internist, and it's that's a big price difference.
All right. Yeah. So can I, as a consumer, maybe this is in your book, do I have any, not just to get educated and go find better deals, go to this app, what is it, GoodRx, and you can see different drug prices and to understand the bill better and to compare and to look at the ratings of the hospitals and do what any consumer would do buying a car or anything else. If I become more of a consumer, can I really negotiate with you, Dr. Trinh? Can I come in and say, no, I don't want to pay $12,000 for your test. I'll give you 10.
Well, if you brought food for me,
brownies.
I'm open to negotiations for food. Yes. By the way, so these CMS ratings, right? What do they actually rate? What are they measuring?
Yeah, that's a good point too.
So, it's interesting because many years ago, let's say, the patient perspective did not matter, right? Because you went to the hospital. If you got a crabby doctor, crabby nurse, or whatever, nobody knew about it but you. You walked away, had a negative experience, you might tell a few people. Or if you had a really good provider, you might tell a few people too. Right. But so they started doing surveys that actually reimburse hospitals based on the surveys of what the patient says. So when the patient says, in my experience, I had to go to the emergency room for a cyst on my chest, right? And I was getting septic, I was shivering and all this kind of stuff. There's a long story in that. My wife wanted to kill me, but anyway, she's a nurse.
Wow.
So anyway, I go to the hospital and, they tell me, okay, we're going to give you an antibiotic after they check me in. First thing is they draw cultures on me, Dr. Trinh. After they give me Tylenol, they draw cultures. Like, we know that's a big no-no. And
it is. Why is that? Because the Tylenol thins your blood or something? Why?
No, it brings your fever down. You should culture me when my fever's up to figure out what's going on with me.
Okay.
Yeah. Sorry. I should do a better job, Paul, at explaining that kind of stuff.
Well, you guys are on Inside Baseball, and we're talking to the real world here, and everybody's going, why? I didn't know. Oh, did you know that? I didn't know that.
Yeah. So they tell me I'm going to get an antibiotic. So the person who's getting me the antibiotic goes to the machine that distributes the antibiotics and comes back and says, sorry, we don't have it right now. We got to get it from the pharmacy. Go back out to the waiting room. And so, the Tylenol affected me. I stopped shivering and all that kind of stuff. Nobody ever came out and gave me that antibiotic. And so when I went back, when a triage nurse came back about 4 hours later and gave me the antibiotic. And then I took that. And then when I was seen, they would try to give me another dose of the antibiotic. I'm like, no, I just took it. They're like, well, it's not here in the electronic medical record
right.
or EMR. I'm like, well, somebody didn't chart it then because I took it. I'm just telling you, I'm not taking it again. So it's just crazy. So I could see why they were a 2-star hospital. They were just making mistakes all over the place. But, especially with the clinician shortage that we are experiencing now and we're going to experience going forward, it's very important to educate yourself on the American healthcare system, because if you don't, you're at the mercy of the American healthcare system when you have to access it. For instance, most errors that happen in a hospital happen around medications. You need to know what medications you're on. And if you don't, you need to call the nurse at your doctor's office and get educated today. And then you need to write it down. Any supplements that you take, you need to print off multiple copies. And if you have to go to the hospital in a non-emergent situation, you hand it to every provider who comes in contact with you.
Okay.
Because otherwise you could get hurt. And when they're giving you medications, the nurse should be scanning them in front of you and explaining what they're for. And the other thing a lot of Americans don't know is that you can bag up your medications that you have at home and take them to the hospital and suggest that they use your medications. It'll lower your bill.
I didn't know that. Let's stop right there, because usually they take all your meds away and then they issue a whole new ones. I've seen this a million times when my late father and mother and aunt were going into the hospital, and the first thing they did is I couldn't bring their medications. I was told they had to get new ones in the hospital there, which they billed us for.
Yeah, that's not correct. The pharmacist has to jump through some hoops to verify the medications, and they don't really like that. So that's probably why you were given that piece of advice, but they have to accept your medications.
Okay. All right. So I'm going to stop you for one more second. And Dr. Trinh, I know has a question. I watched my late father, my late mother, and her sister, who never got married, my maiden aunt, all die over a number of years. And I, being an only child, I was the only one there for all of them. And I learned the importance of being a patient, an educated patient advocate for them, because, particularly as I got old, we gave that to her. No, you didn't. Isn't it time for this medication? We forgot about it. 4 hours goes by, 3 hours goes by. And I'm not saying be a pain in the butt, but you got to be there paying attention, because they're so overwhelmed, so short, so frantic. They are making mistakes left, right, and center. And if somebody isn't monitoring it on the patient's behalf, medications get missed, they give them the wrong stuff at the wrong time in the wrong amounts, or they give it to them again. And to the silliness, I'll leave with this last one. My aunt towards the end of her life, had to have a knee replacement, which they didn't want to do at her age, but she couldn't walk. So what do? They marked in a black pen at the last moment. Some nurse said, "Now, is it the right knee?" And she said, "Yeah." And we both said, "Yeah, it's the right knee." And she put a black magic marker on the right knee, an X, so there can be no mistake when the doctor goes in and says, "Which knee is it?" And he just starts operating on the wrong one. That's the ridiculousness that goes on.
Well, they did that because that is a metric that they're evaluated on, because other people have done the wrong knee before.
Yeah.
So that became a regulatory item many years ago.
So you've not only got to be educated about what you're paying for and be a consumer and shop around, but you've got to be an advocate for your own health care once you enter the system, because it's a rabbit hole. It's Alice in Wonderland. Up is down, black is white, and confusion reigns, and mistakes get made in the middle of that confusion.
Yes, that's correct. And that's why you want to have an advocate with you, especially if you're having surgery. And in my book, I talk quite a bit about getting a nurse in your network. Talk to a nurse. Nurses like to help people, right? Get a nurse in your network who can give you advice that you can text. And so just to clarify, I am a nurse with a doctorate degree.
Okay.
This book being written, and no offense to physicians, but you guys come in, you diagnose, and then you're gone, right?
And you're out of there.
Right. And then you give them to us. And I'm like, okay, I got to hold this patient's hand while, their loved one's dying or whatever. I go into those innermost spaces as a nurse. Right. So it was very important to me that a nurse really wrote this book, because the stuff that I've seen in the healthcare system in almost my 30 years in healthcare, some of it I was just shocked with. Nursing school never prepared me for some of this stuff. And so that's why I think it's important that a nurse write a book like this.
I think so too. He's had another nurse on, what's her name? I always forget, Kagan. What's her first name? Who's your Irish friend?
Nurse Edna?
Etna.
Yeah.
She has an Etna Kagan. She's Irish and she's very feisty. And isn't she like that?
Feisty.
Oh, she is. She's feisty as they come. That's the Irish in her. She gets her Irish blood up here. And I forgot her ranking in the nursing world, but she's some senior nurse of some sense. And she's always railing against the fact that, that people, some of what you're saying, people just aren't paying attention. They don't know what's going on. There's chaos, there's confusion, everything. Is that just the system, or can we slow it down and make less mistakes?
Yeah, no nurse or doctor goes to work expecting to do crappy work. Let's just put that out there.
Right.
But the system itself in fee-for-service means that Dr. Trinh has to see a certain amount of patients in order to get paid.
Right.
And the nurse has to take a certain amount of patients on the floor, which doesn't give the nurse time to study the chart and really get to know you.
Right.
So they don't know your health history. They're just running around with their hair on fire. And that is the design of the fee-for-service system. And that's why I go back to value-based care to say when clinicians are incentivized to keep you healthy, you know, I mean, one of the things that the listeners can do is call their doctor and ask them if they're part of an accountable care organization. It sends a strong message.
Accountable care organization. What is an accountable, as another acronym, what is that?
Okay. So basically it's like a bunch of doctors who are together in a network. Okay. And so if you're seeing you're seeing a general practitioner, right, and they're going to refer you to a cardiologist, they would be in the network. And they can reduce the cost. So they just basically administer this. But the real meat that people need to know is that they're incentivized to keep you out of the hospital, keep you healthy, to keep you at home. Another thing.
And how are they incentivized to do that? It's a penalty. So if you, like you gave the other example, if they
financial.
Financial. So the insurance company gives a certain amount per head, per patient, and says, you go at risk, doctor.
Lump sum. Here it is.
Accountable care. You go at risk. We don't want to go at risk anymore.
And so it's a lump. The insurance says, here, knee, here it is. Here's $12,000. Make it work. And if they don't make it work, they give you, like in your example, they give him the wrong drug and he's got to go to emergency. They have to eat that cost because they ain't getting anything more. It's 12, not from the patient, not from the insurance company. If they do it right, they make some money. If they do it wrong, they lose money.
That's correct.
Define value-based care.
Yes.
What does that mean?
That's the next term, right?
That's getting paid simply what you said earlier. It's getting paid on the outcomes, not just the procedure, not doing the test to do the test, which you get some financial incentive for. You get paid on the outcomes of what the patient. Yeah. So
how would that work? Same example, knee. We're saying a knee is $12,000 or whatever it is. So on a value, on a pay per service, they can do as many tests as Medicare will pay for, and maybe they want to do a lot of tests because it covers their butt and they don't get sued, and so there's always an incentive to do more tests from a legal perspective and from a financial perspective. I always hear, but on a value-based system, the hospital gives, or the insurance company gives them a lump sum, make it work. If it's not enough, you got to pay for it. You're at risk, doctor, for our group of doctors or hospital or whoever's doing this. How does it work then? Do they just, I'm still struggling. So they have a lump sum what to do with. Yeah.
Yeah. Let me give you another example of something that happened to me that, so I was in a grocery store where I lived, and I heard somebody talking to somebody else, and they were talking about getting a procedure done at the hospital, and they mentioned a surgeon that did not have quality outcomes. This guy he had bad hands and bad judgment. We've all seen it. And so I'm thinking to myself, crap, I wish I didn't hear that conversation. And I'm in the frozen food section, and this lady comes right down next to me. And I'm like, hey, I overheard what you said about getting a procedure by so-and-so at the hospital. And I said, I can't tell you who I am, but I can tell you this. I work at the hospital, and his outcomes are not as good as the other people in his practice. I said, you really need to change your doctor.
Wow.
And I went away from that conversation. This is a moral dilemma, right?
Yeah,
that would have been a totally inappropriate conversation to have if I was prepping her for surgery.
Yeah,
and I was working at the hospital. But I was in the grocery store in the community, and I thought, man, I just don't want to see her go through that. And when I saw her at the hospital, she was under a different doctor. So she listened to what I had to say. But, so value-based care weeds people like that out, because if they're in your network and they're having bad quality outcomes, you can't make value-based care work because you're going to eat the cost every time.
You're going to go broke.
Come back. Yeah. So does that help?
Okay. All right. So why isn't everybody in value-based care? I love it. Well, let's pull a magic string, and overnight everybody's in value-based care.
Okay, so there's some complications with that. Only 25% of Americans even know this exists.
I didn't.
Yeah. Okay. So there you go. You're part of that gifted 75% that we're trying to educate this hour.
Ever heard of it?
Right. So again, I went back to the fact that ask your doctor if they're part of an accountable care organization. It sends a strong message, because if he says no, and you say, well, I want to be referred to a doctor that's part of an accountable care organization, he's like, crap, I'm going to lose patients if I don't wake up to this. But I also read a survey, and be interested to know, Dr. Trinh, what you think about this. 61% of physicians think it will affect their income negatively, according to the statistics that I saw, which was probably about 2 weeks ago.
Because they're taking on some risk. They're now at risk for the outcome.
But aren't they always at risk anyway for the outcome when you think about it?
I mean, it will affect their income negatively if the bulk of their income today is from procedures that they are doing.
Yes.
Yep.
And obviously it's going to affect, because you're putting you're basically putting a budget, right, onto healthcare.
Right.
Whereas in a fee-for-service world, there is no budget.
Right.
Bingo. We have a winner.
We have a winner, ladies and gentlemen. Dr. Trinh, as usual, cut through the BS down to the basic bottom line here. All right, so why then? Is it just a resistance of physicians, or is it resistance of drug companies, or lack of education and demand by the consumers? Why are so few people aware of this or using it?
Okay, so we'll have to dive a little deeper into some numbers. So, so let's talk about COVID. Okay. So when people weren't going to the hospital, we, the taxpayers, bailed them out, right? Because we had to keep the doors open to the hospital. So we released all this money to hospitals because they were not seeing procedures. Meanwhile, in value-based care, they saved $4.1 billion. Because they got the money whether you showed up or not. In fact, in the infrastructure bill, there were about 10 hospital systems and physicians who called the Senate and Congress leaders in healthcare and said, look, we saved all this money in 2020. We think we can save you $313 million if you'll just implement the Value-Based Care Act within the infrastructure bill, and we'll help you pay for the infrastructure bill. I just read what was in healthcare in the infrastructure bill. There's a lot for broadband in rural communities, but that never made it past anybody. So they're not incentivized. And so I will say,
but I got to stop you, because you say that like we all understood it. So under a value-based care system, hospitals weren't doing procedures because they're filled up with COVID patients. So we're not doing elective procedures, the stuff the bread and butter we're making money off of.
Yep.
So the healthcare system suddenly felt like it lost revenue. And so we, the consumer, stepped in and gave them additional financial assistance to keep the hospital doors open.
Money.
But you're saying those that were operating on a value-based system, they'd already gotten paid a lump sum. And if people didn't use it, they got to keep that lump sum. It was a profit because they didn't do procedures.
Yep.
So therefore, under a value-based system, it can work both ways. If I get a lump sum and I don't use it all, I keep it. If I use too much, I'm at risk and I got to pay more. So it's more entrepreneurial, right?
Correct.
It's the same model as capitation, right?
Yes.
What's capitation? I've heard of decapitation, where they cut your head off, but I've never heard of capitation. What's capitation? Go ahead.
Yes, capitation. I hate to use the word capitation only because it reminds me of the HMOs and things that we tried many years ago that did not work. So under value-based care, yes, you do get a capitated amount for the patient, but you're in a network of providers who are incentivized to keep you healthy, whereas the HMOs weren't like that, right? So that was a pretty bad model, our first attempt at it. Capitation is good if you're being looked after and if you're being cared for properly. And let's go way back to, the community doctor that used to come to your house.
Yeah, that's what I want to go back to. The guy came over to my house with his bag, and he was there from birth till death. He was there to take care of me. And old Doc Marcus Welby, we loved him.
So in that model, not only do I get to see your physical surroundings, I can see what you're eating. I can see, and I mean, there's so much more to healthcare.
That's true.
You know, actual healthcare itself is like 20% of the model. Social determinants of health, or the zip code that you live in, really decides your fate in the healthcare industry, right?
Now,
So
you know, you say that casually. That's a pretty shocking thing. Your zip code decides your survivability rate in the system. Why? Because lower income people are eating poor. They're in environmental hazards. They're maybe less educated as to choices and whatnot. And the more affluent outcomes, what? They got more money, they got more education, they got a better living environment, better food, maybe, all of that.
You just nailed it.
Okay.
The only thing I can add to that is, let's talk about, you know, going to Whole Foods and getting an organic salad for lunch, which is going to set you back at least $8.
Right.
Or if you don't have a lot of money, you can go to McDonald's and get a Happy Meal full of fat and grease, and that affects your healthcare. Your macro decisions or micro decisions that you make every day. You know, whether you're going to get out and walk your dog or you're going to binge surf Netflix, you know, on the couch, makes a difference to your total healthcare.
Netflix.
He's a Netflix. The zombie movies. He loves zombie movies. All right. So you're saying that when we used to go out into the see the patient and not have them come to us, which seemed less efficient, more travel time, more whatnot. But now we bring them all into a central processing and it's an assembly line and we can crank them through quickly here. That seemed more efficient, but we get less information about the patient.
That's correct. So this is a prediction I'm going to make. So with this clinician shortage, we're already seeing people set up hospitals at home. So patients that aren't really sick but need to be cared for can be cared for in their home environment using technology. So a good example of how value-based care would work.
He's all over that.
Yeah, right. So if you had congestive heart failure or accumulation of fluid in your lungs or your lower extremities because your heart wasn't pumping as well. Is that good, Paul? Did I explain that well?
You got that one. All right. I'm getting it. You got to be, this is medicine for dummies today here. I got to be real clear. All right.
Okay. So your heart isn't pumping as efficiently as it should. Now, most of the time, these guys will start to not walk as much. They'll get short of breath, and then they go into a full-blown crisis, and they come to the emergency department. They spend a couple of days in the hospital. Everybody makes their money, and then they go home, and they might do it again in a month or 6 months or whatever. Under value-based care, they would issue you a blood pressure cuff, some wireless scales, a pulse oximeter to measure the oxygen in your blood, and they would send you home telling you take your blood pressure at certain times, you get on the scales every morning. Maybe they're even connected to your Fitbit or your Apple Watch, right? So that they can see how long you're walking. And then there's a position that's pretty recent called a nurse navigator position. And what the nurse navigator does is the nurse navigator looks at your data as it comes in, and there's software that can actually bump up the people that are most at risk in this model, which I would strongly recommend. And so they'll see it and they'll say, hey, you know, Paul, I just noticed that like you're not walking so much anymore, and you gained 4 pounds in the last couple of days. How are you feeling? Oh, I'm a little bit short of breath. Well, they can intervene on you before you go into that full-blown crisis that costs everybody a bunch of money once you hit the emergency room. And so, you know, that's the model. That's value-based care. That's people looking out for you as opposed to just, you know, collecting money when you show up.
It's remote patient monitoring.
Right, exactly.
Yes, and that's the
Dr. Trin's all over that. We talked about that a million times. Big believer in it. Now, all right. So here's. I know we got only a couple minutes left here, and we want to get some tips. But I want one more quick answer from both of you. Why isn't this being widely adopted? Why is it still a theory more than a practice? Value-based medicine, looking out for you rather than treating the outcome, rather than just procedures. Dr. Trin, why is this still rare and hard to find?
Probably because fee-for-service model is still a very big model in the United States. Fee per service. Every service, every procedure, right, rather than outcome is still a very big model.
And so who's driving this? The doctors that want to make money, the insurance companies that want to keep control, the drug companies that want to profit off of this, all of those, who's fighting to change this then? It seems like nobody is.
I would say that that's correct, except like that 10 hospital system that wrote and tried to get the Value-Based Care Act into legislation. There's so many variables, and we could do a whole show on it, Paul. But politically, our politicians, they all go in and they say they're going to attack high drug prices, and then all of a sudden it's crickets, because 43 million went into the 2020 election on both sides of the aisle. People aren't touching it. We get executive orders every once in a while, but we don't get bipartisan legislation, which means a lot more. So it's the
all of that, exactly, all of that. A lot of talk, a lot of incentives. In the end, nothing happens. And I'm wondering if there's just too much money, too many special interests baked into the system, and the consumer doesn't understand the choice. I didn't know there is a choice, and they're not advocating for it or pushing it or being consumers or being voters and voting for those who support these things. You mentioned in the Infrastructure Act that there was an a Value-Based Care Act within it. I didn't know that.
No,
it was an Infrastructure Act. It was supposed to build bridges.
It died. Yeah.
It died.
It died. Even though it could have saved $313 million. See, and that's exactly why I wrote the book, How to Avoid Being a Victim of the American Healthcare System, because I want people to be educated and safe. I got a buddy who used to head up the New York State Troopers, and he tells me, when the black cars start following you around, he's like, you better call me.
You better call me, because there's people out, we don't need you saying this, doctor, please.
Right. Exactly.
Why don't you just take a long vacation? Here's some money and leave. Right. All right. So in the last 5 minutes, give us some, I know you must have lots of tips in there. You're giving people a survival guide to get out of the system. Give us some of the top tips or some simple takeaways that we could put into practice today here. An incentive to read the book and learn even more.
Sure. So like I talked about, the first part of the book is how to stay safe in the hospital. Right. It talks about advanced directives and having people that when care is no longer necessary, instead of pounding you, you know what I mean, with intubating you with tubes and stuff, have somebody that says enough is enough. David didn't want this. Okay. And then the second part of it is, how do you decrease your high prescription drug prices? Because there's lots of people who make decisions about whether they're going to pay rent, buy groceries, or buy their medications. A lot. Yes. Yeah. 44% of Americans are $400 away from a healthcare crisis. Yes. 58.5% of personal bankruptcy is due to healthcare bills. Wow. Then there's things like surprise billing. Like there was a helicopter company that charged somebody $58,000 because they were out of network to get them between two cities for a double lung transplant. And then when Good Morning America picked up the story, they settled for nothing. So, there's lots of stuff like how you use media, how you would use a politician to help you actually settle an insurance claim is in this book.
A politician to settle. I'm going to go to my congressman to help in their office to help me
I'm going to have to read this book.
Yeah.
You definitely, I actually did that for my aunt's estate where they wouldn't settle the bill. And I kept calling and they were like, you have to talk to so-and-so. And I would call, they're on vacation. I would call a week later, 40 minutes on hold, and then I get disconnected. So a medical doctor friend of mine said, you need to call the senator's office. And so I did. And as soon as I was on hold 30 seconds, I got an aide. I said, here's what's happened. I'm trying to settle this estate. They won't pay the bill. He said, we got people over there. He goes, I'll take care of this for you. 5 days later, I got a notice it was going to be paid. And 2 weeks later, I had a check. But the average American doesn't know that.
No, I didn't know that. Yeah. I would never call
books.
Yeah.
I got it right here for you.
Yeah, hold up one.
This is what it looks like. It's on Amazon.
Tilt it down just a little bit because it's reflecting. There you go. How to Avoid Being a Victim of the American Healthcare System. I got to tell you, this is a book every American should pick up. I should read. Dr. Trinh should read, and everybody listens. Why? Not because we're trying to sell your books, because I believe there is a real problem. Having been through it with 3 people dying over a long period of time, I have discovered that the last thing in the world, like the legal system you want to enter, is the healthcare system. When you start going down the legal system, having gone to law school, boy, you are into a rabbit hole, and it's hard to get out of the legal system. And one cost leads to another, and one bad thing leads to another, and pretty soon bad things are happening, and you don't know how to get out of this hole. You don't know how to fight it. The same thing in medicine. You want to do everything you can to stay out of the hospital, out of the healthcare system, because once you go down, bad things start happening, bills start piling up, and confusion reigns. So stay out. And if
so the last part of the book has to deal with how do we make the system better? Right. Things like remote patient monitoring, things like value-based care. I even cover genetic testing in it. Is it a good thing for you to do, or is it not a good thing for you to do? And
I always wonder about that because I have certain genetic tendencies, and I wonder, should I really get tested and see if I'm susceptible to heart or this or something, or do I just not want to know? I don't want to know that it's
so we could do a whole show on that and what happens with your data once you're tested. So you'll definitely want to read the book, because that's how they caught a serial killer in San Francisco. Was his relatives were uploading their DNA, and the investigators went back with what DNA they had, and it was declassified and sent out and all that kind of stuff, but they were able to put it together. You can reclassify that information. So that's why I say I covered it, because average American who's spitting in the tube for 23andMe, they don't know that, right? Yeah. They're like, I'm going to find out if I have any, funky relatives or that kind of stuff. But
I did. I went to Ancestry and spit in the tube just so I could find out where I was from. Yeah, exactly.
Yeah, so you definitely want to read that. But that's what the book is all about. I'm just breaking it down. I'm not here to make a lot of money with this book. I just want people to be informed. If people can be informed and they can be a better partner in their healthcare, then that's what it's all about. At the end of the day, it's like I said, healthcare is complex and it's designed that way for a reason. Let's get the information in people's hands and make them safer when they have to access the healthcare system, or inform them what to do with the pharmaceutical company or the insurance company. That's
so here's my takeaway, Dr. Trinh. I'll throw it back to you. You got to have this guy back again. We've only scratched the surface. We come up with 3 or 4 other topics. Yeah, we
need a part 2. Dr. Wilcox, I will shoot you an email on available dates for part 2.
Okay, that sounds good. I'd love to get this message out. I just want, like you do, we see all this stuff and we just want to help people.
By the way, I'm the CMO of a health insurance company.
Are you really?
How
do you like that?
Oh yeah, no, totally.
You're part of the dirty rats that are stopping this thing from happening. That's it. You're probably going to bury this show. Now I get why you want them on. You want all this stuff, and you're going to bury the show.
All for it. Patients first, members first.
Yes, definitely.
Definitely. That's the direction we are leading, right?
Would it be fair to say that most physicians and nurses, we tend to think of them as the enemy, like bureaucrats at the insurance companies? I don't know that their heart is in the wrong place. I think they're just operating in a system that is fatally flawed. I don't know. Like you said, do most doctors and nurses go to work today and say, I'm just going to do a bunch of procedures and make a bunch of money and screw the outcome. I don't care if I help anybody. I don't know. That's why you all spent years studying this thing and do this job. I think that's a wrong assumption, but we make all the time.
Yeah, they're not set up for success, Paul. I think, right. And Dr. Trinh, I think you'd agree with me on that. They're just not set up to be successful. More patients you see, the more money you make for the hospital. And you got the bean counters at the top of the hospital chain that are just like, we got to do this service line because we'll make more money if we do a orthopedic line or a bariatric line. Right. We're going to make more money, right? And so that's crazy. But Dr. Trinh, if you ever need somebody to set you up a value-based care organization, I'm your guy. Call me, buddy.
I love it.
Yeah, I want to know more about this. So let's come back and let's talk about let's go to one topic and the next one, like value-based care or DNA testing, or let's pick something very specific. Maybe there's more than one show, and let's do this. Yeah.
Let's do a series.
Yeah, we could talk about the political structure and how politicians are de-incentivized to do anything about healthcare costs. I think that would be a good topic because not a lot of people know what the number, where you find that information, So you can get online and you can find out who's contributing what to your politician.
That's important, but it's depressing. We all assume that they're all bought and paid for these days. So I don't know. I'd want to know more what I can do proactively to not be a victim when I'm in the system, and specifically to look at alternative models that I've never heard of. Value-based system, you all say there was an act out there. I never even heard of the act, much less the idea.
Know what's interesting is I see sometimes legislation pass through regarding our healthcare. It's new laws, new rules, and they exempt Congress from participating.
Oh, all the time.
Yes.
Affordable Care Act.
It's like, if it's good for America, why is Congress exempt?
So, Dr. Trinh, let's talk a little bit about the Non-Disclosure Act, which doesn't allow the Secretary of HHS to participate in driving down costs or negotiating costs for Medicare. So that's a law. He can't, in socialized medicine, I'm going to buy 2 million low pressures. I can say, they can say $2 a piece, and I can say $1 a piece. I represent 2 million people. Medicare, you can't do that. That costs people in Medicare over $11 billion a year. And the guy who rammed that through, he is working for a foundation, a pharmaceutical foundation, making $2 million a year. That was his reward for ramming it through. Like I said, you have to understand what's going on in order to address change. And change needs to happen in Washington. I'm telling you.
Well, and Washington's one place, but I'll tell you the other thing is change has to happen in our mind. Because the minute I don't care what it costs, then politicians and drug companies can charge whatever they want, because I don't care. But if I'm an informed consumer, not just an informed voter, but an informed consumer, if I care, if I'm putting the bill, this whole system would be different. If I had to pay for everything out of pocket, I guarantee you prices would come down, services would change.
Definitely.
100%. Yeah, as a patient, you don't pay the hospital bill. You're just hospitalized. You pay your copay,
right?
But you don't know the amount behind there, so you're not informed, and you just don't care.
My late mother had Parkinson's and other things, horrible end of life, and was in and out of the hospital many times until she finally died. She got so weak and she just died of something. I don't know if she got pneumonia or something and died. And when she died, lingered over a while. My father got a bill that came from the hospital for that final week of intensive care, and it was over $1 million to die. And at first he was horrified, and then he said, oh, thank goodness we have umpteen different insurances and Medicare and private insurance, and she had insurance and everybody. And so he didn't pay anything. So he threw it away. I've never forgotten that. Somebody paid $1 million just to take care of my mother while she was dying. That's wrong.
Yeah,
that's wrong.
That is wrong.
And until all of us stand up and say, that's wrong, I don't care if I didn't have to pay for it. It's wrong, and I think that should change. Then nothing will change. The politicians won't change. The drug companies won't change. The hospitals won't change. I think it's got to start with us. And that's where I think this book can inform people and get them not just enraged at the politicians and the drug companies. We're already enraged at them, but to get us enraged enough to do something about it and to take back control of our own healthcare system. That's my rant this morning. I don't know if anybody will join me as we fight the system, but let's come back and do more here. Yeah.
Yes, let's come back and do more, guys.
How to give us the book one more time, and then we'll wrap up.
Sure. It's available on Amazon. It's called How to Avoid Being a Victim of the American Healthcare System, A Patient's Handbook for Survival.
Love it.
So stay educated, stay safe, everybody.
And stay active. Stay active to stay out of the hospital and be actively involved when you are in your own healthcare. Active.
We're going to do part 2. I'll send you some dates.
Okay, very good.
Sounds good, Dr. Trinh. I'll be looking forward to it.
All right. Thank you.
All right, there you have it. An active reason to tune in each and every week here for the one show actively trying to help you navigate the healthcare system and figure out ways to be healthier, happier. Right here in Orange County's only community radio station, octalkradio.net. Streaming live from the University of California, Irvine's Beale Applied Innovation Center.